Welcome to our clinical scenario challenge. In today's case, we will explore a critical situation involving a 24-year-old primigravida at 34 weeks of gestation who has been brought to triage in an unconscious state. This scenario will test your clinical reasoning and decision-making skills. Let's begin. As part of the evaluation process, we need to gather essential information from the accompanying relative. I will ask Rogers a series of questions regarding this case. Rogers, what important questions would you ask the aunt regarding this patient's condition? Please provide at least 4 questions. 4 marks.
Thank you, doctor. I would ask the following questions. Number 1, is there any history of bleeding during the pregnancy? Number 2, has she been hypertensive or was hypertension noted during this pregnancy? Number 3, is there any recent history of malaria? Does she attend antenatal care, particularly assessing if she has been receiving fancied? Number 4, has she experienced any seizures prior to this unconscious state? Is she known to be epileptic?
Excellent questions, Rogers. Now, let us discuss potential differential diagnoses. What are 4 possible diagnoses you would consider for this case? 4 marks.
The differential diagnosis I would consider: number 1, eclampsia; number 2, meningitis; number 3, cerebral malaria; number 4, hypoglycemic shock; number 5, severe anemia; number 6, antepartum hemorrhage; number 7, epilepsy.
Very thorough, Rogers. Now, during your physical examination, what important signs will you look for? Please list at least 4 signs. 4 marks.
In my examination, I would look for the following signs. Number 1, edema. Number 2, blood pressure greater than 114/90 millimeters of mercury. Point 3, increased respiratory rate. Point 4, increased pulse rate. Point 5, elevated temperature. Point 6, signs of anemia such as pallor. Point 7, capillary refill time which may be prolonged. Point 8, increased symphysis of fundal height greater than the gestational age.
Very well articulated, Rogers. Now, let's discuss the investigations you would order to help arrive at the diagnosis. Please list at least 6 investigations. 3 marks.
I would order the following investigations. Point 1, urinalysis. Point 2, ultrasound scan. Point 3, random blood sugar. Point 4, full blood count. Point 5, blood urea nitrogen and creatinine levels. Point 6, liver function test. Point 7, renal function test. Point 8, prothrombin time and partial thromboplastin time. Point 9, uric acid. Point 10, blood group and cross match.
Excellent responses, Rogers. Thank you for your well thought out answers. This concludes our clinical scenario challenge. We hope this exercise has provided valuable insights into the management of complex obstetric emergencies. Stay tuned for more scenarios and educational content. Thank you for watching. Welcome to today's medical dialogue. I am Dr. Scenario, and in this video, we will explore the important topic of hypertension in pregnancy. We have with us Rogers, a medical student who will answer some clinical questions based on a presented case scenario. Let us begin with the scenario. Imagine a nullipers woman who is 30 weeks pregnant. She presents to the woman and newborn hospital labor ward with hypertension. We will discuss various aspects of her condition and appropriate management. Rogers, can you please define hypertension in pregnancy?
Hypertension in pregnancy is defined as an elevated blood pressure of more than 140/90 millimeters of mercury, measured on 2 or more occasions, 4 hours apart, in a woman with a gestational age of no less than 20 weeks. This definition accounts for the unique physiological changes that occur during pregnancy.
Thank you for the definition, Rogers. Now, can you classify the different disorders of hypertension in pregnancy?
Certainly, the classification of hypertension disorders in pregnancy include the following. Number 1, gestational hypertension. This is characterized by elevated blood pressure of more than 140/90 millimeters of mercury. that begins for the first time after 20 weeks of gestation and resolves after pregnancy. Number 2, preeclampsia. This condition involves elevated blood pressure of more than 140 over 90 millimeters of mercury that begins for the first time after 20 weeks of gestation, accompanied by proteinuria of 3 plus or more, or any level of proteinuria with signs of end organ damage. 3. Dyseclampsia. This is preeclampsia complicated by grand mal seizures and or coma. Number 4, chronic hypertension. This refers to non-hypertension before pregnancy or first occurrence before 20 weeks of gestation. Number 5, chronic hypertension with superimposed preeclampsia or eclampsia. This condition occurs when there is chronic hypertension with the new onset of proteinuria or signs and symptoms of end organ damage. 10 marks.
Excellent, Rogers. Now, what investigations would you order for this patient?
I would order the following investigation. Full blood count to check for hemoglobin, red blood count, and platelet count. Serum uric acid levels, liver function test to assess liver health, renal function test to evaluate kidney function, urinalysis to check for proteinuria, and an ophthalmologic examination to assess for hypertensive changes in the eyes. Fetal monitoring to ensure the well-being of the fetus.
Thank you for that comprehensive list of investigations. Upon admission, the patient is placed on magnesium sulfate. How would you monitor her while on this medication?
Monitoring a patient on magnesium sulfate is critical. I would implement the following measures. Number 1, monitor urine output by connecting a urinary catheter and checking hourly. The urine output should be 30 millimeters per hour or more. Number 2, assess the respiratory rate every hour, ensuring it is greater than 16 breaths per minute. Number 3, check for deep tendon reflexes every hour to monitor for signs of magnesium toxicity.
Thank you, Rogers, for your insightful responses. Hypertension in pregnancy is a critical condition that requires careful management and monitoring to ensure the safety of both the mother and the fetus. Thank you for joining us today, and we hope you found this dialogue informative. Hello and welcome to this medical dialogue challenge. Today, we will be discussing a clinical scenario involving a 24-year-old woman named Ms. Sharma Mulenga. She is currently on combined oral contraceptives, but has missed some pills over the weekend. Our student, Rogers, will respond to various questions regarding her situation. Let us begin. Ms. Sharma Mulenga comes to your clinic seeking assistance after missing several active pills while attending a funeral. She presents a pack of her contraceptive pills, with only 2 active tablets remaining. She expresses a strong desire to continue taking the pill and has some concerns regarding her situation. Now, let us explore how you would respond to her concerns. Rogers, what advice would you give to Ms. Sharma regarding her missed pills? This is worth 3 marks.
I would advise her to take the remaining 2 active pills one at a time as scheduled, discard the inactive pills and then start a new pack immediately after completing the current pack. This approach ensures she maintains contraceptive efficacy moving forward.
Can you explain how the combined oral contraceptive pill works? This question is worth 2 marks.
The combined oral contraceptive pill contains both progesterone and estrogen in calculated amounts. The progestin component inhibits ovulation by exerting negative feedback on the hypothalamus, leading to a decrease in gonadotropin-releasing hormone release. This in turn reduces the release of luteinizing hormone and follicle-stimulating hormone. Concurrently, progesterone thickens the cervical mucus, making it more difficult for spermatozoa to ascend into the uterine cavity. The estrogen component works through a negative feedback mechanism on the anterior pituitary gland, further decreasing follicle-stimulating hormone and inhibiting follicle recruitment and maturation.
What can you tell me about the use of the combined oral contraceptive pill as emergency contraception? This question is worth 2 marks.
In the event of unprotected intercourse, the combined oral contraceptive pill can be used as emergency contraception. within 120 hours of uterine exposure to spermatozoa. The individual should take 2 high-dose combined oral contraceptive pills followed by an additional 2 pills 12 hours later. This regimen can help prevent unintended pregnancy.
What non-contraceptive benefits of the combined pill can you inform Ms. Mulengo about? This question is worth 2 marks.
The combined oral contraceptive pill has several non-contraceptive benefits. These include the regulation of irregular menstrual cycles, treatment of amenorrhea, management of dysmenorrhea and menorrhagia, and prevention of ovarian and endometrial cancers. Additionally, it can help prevent pelvic inflammatory disease, manage hirsutism and acne, and offer protection against endometritis.
Lastly, could you list 2 absolute complications of the combined oral contraceptive pill? This question is worth 1 mark.
2 absolute complications of the combined oral contraceptive pill include weight gain and breakthrough spotting. Additionally, headaches may also occur, which I mention as an extra point of consideration.
Thank you, Rogers, for your detailed responses. It is essential to understand both the therapeutic benefits and potential complications associated with the combined oral contraceptive pill. This concludes our discussion for today. Thank you for joining us, and we hope you found this session informative. Hello, and welcome to our Medical Dialogue Challenge. Today, we will explore a clinical case involving a 40-year-old nullipera, Mrs. Kakuza, who presents with certain symptoms. This case will help us understand the management of leiomyomas of the uterus. Let us begin by discussing the patient's scenario. Mrs. Kakuza, a 40-year-old nullipera, presents to the clinic with the complaints of easy fatigability. Upon examination, she is found to be pale with a palpable firm abdominal pelvic mass of approximately 28 weeks size. An ultrasound scan confirms the presence of leiomyomas of the uterus. I would like to ask you a few questions regarding this case. Question 1. What other 3 symptoms are you likely to elicit on further inquiry? 3 marks.
The 3 likely symptoms I would elicit on further inquiry are menorrhagia, dysmenorrhea, and recurrent pregnancy loss, also known as miscarriage.
Question 2. What is the major risk factor for this condition that Mrs. Kakuza has? 1 mark.
The major risk factor for this condition is nulliparity.
Question 3. What other investigations will you carry out in this patient to help you with management? 2 marks.
To aid in the management of Mrs. Kakuza, I would conduct several investigations, including point 1. Transvaginal ultrasound, point 2. Saline infusion sonography, point 3. Hysteroscopy, point 4. Full blood count or complete blood count, point 5. Uterine curettage, point 6. Dilatation and curettage, point 7. Endometrial biopsy.
Question 4. What non-surgical and surgical options are available for the management of this patient? 4 marks.
For non-surgical management options, we have number 1. Gonadotropin-releasing hormone antagonists, such as ganirelix. Number 2. Gonadotropin-releasing hormone agonists, such as leuprolide. Number 3. Antiprogesterone. For surgical management options, the following are available. Number 1. Hysterectomy. Number 2. Myomectomy. Number 3. Embolotherapy. Number 4. Myolysis.
Thank you, Rogers, for your insightful responses. This case highlights the importance of a thorough evaluation and understanding of management options for patients with leiomyomas. Join us next time as we discuss another intriguing clinical scenario. Welcome to today's video dialogue, where we will explore a clinical scenario involving a pregnant patient. We will assess the situation and provide answers to relevant questions. Joining me today is Rogers, a dedicated medical student. Let us begin with the scenario. Rogers, today we have Mrs. Memory Zulu, a 26-year-old woman who is currently in her 2nd pregnancy at 29 weeks of gestation. During your abdominal examination, you note that the height of the fundus measures 36 weeks. Let us discuss this observation. What terms used to describe this finding? 1 mark.
This observation is described as large for gestational age.
Correct. Now, what is the most common cause of this discrepancy? 1 mark.
The most common cause for this discrepancy is gestational diabetes mellitus.
Excellent. Now, can you list 4 other differential diagnoses for this finding? 2 marks.
Certainly, the differential diagnoses include number 1, polyhydramnios, number 2, multiple pregnancy, number 3, uterine fibroids, number 4, inaccurate dates.
Very well. Now, upon reviewing an ultrasound scan, you discover that Mrs. Zulu is carrying 2 babies. Can you list 10 complications that can arise from twin pregnancies during the antenatal period? 5 marks.
The complications that can arise include point 1, cord prolapse, point 2, cord presentation, point 3, malpresentation, point 4, twin-to-twin transfusion syndrome, point 5, vanishing twin phenomenon, point 6, fetus papyraceous, point 7, placenta previa, point 8, placental abruption, point 9, hyperemesis gravidarum, point 10, anemia, point 11, preeclampsia, point 12, preterm labor.
Great job listing those complications. Finally, what 2 findings would you look for in your abdominal examination to support the scan results? 1 mark.
In my abdominal examination, I would look for point 1, fundal height greater than the period of amenorrhea, point 2, palpation of 2 fetal heads, point 3, a barrel-shaped abdomen.
Thank you, Rogers, for your thorough answers today. This concludes our discussion on the clinical scenario of twin pregnancies. It is essential to recognize the implications of such findings during antenatal care. Thank you for joining us, and we look forward to seeing you in our next session. Hello everyone, and welcome to today's Medical Dialogue Challenge. In this session, we will discuss a critical clinical scenario involving postpartum hemorrhage, a significant complication that can arise following childbirth. Joining us today is Rogers, a dedicated medical student who will help us navigate through this case. Let us consider the case of Mrs. Situla, a 30-year-old woman who is a gravida 4, pair 3. She experienced a vaginal delivery at home. Following the delivery of the placenta, she began to bleed severely and was subsequently rushed to the hospital, where she presented to the emergency room. Upon examination, she brought the placenta with her, which was found to be complete. Rogers, let's begin with the first question. What are the risk factors for postpartum hemorrhage? This question is worth 2 marks.
The risk factors for postpartum hemorrhage include the following. Point 1, a history of postpartum hemorrhage. Point 2, obesity. Point 3, advanced maternal age of more than 40 years. Point 4, coagulopathies. Point 5, leiomyomas. Point 6, anemia. Point 7, grand multiparity. Point 8, multiple pregnancies. Point 9, hydramnios. Point 10, macrosomia. Point 11, antepartum hemorrhage. Point 12, prolonged labor.
Thank you, Rogers. That was comprehensive. Now, moving on to the next question. What should be done immediately after delivery to prevent postpartum hemorrhage? This question carries 1 mark.
Immediately after delivery, it is essential to check for and remove any retained products of conception to prevent postpartum hemorrhage.
Excellent. Now, can you elaborate on the medical management options available for atonic postpartum hemorrhage? This question is worth 2 marks.
The medical management options for atonic postpartum hemorrhage include point 1, uterine massage until it is fully contracted. Point 2, administering an intravenous infusion of 20 international units of oxytocin added to 1000 milliliters of normal saline. Point 3, administering 10 units of oxytocin intramuscularly or 0.2 milligrams of methyl-egometrin intravenously. Number 4, catheterizing the bladder to ensure it is empty.
Great answers, Rogers. Moving on to our next question. Besides an atonic uterus, what other causes of postpartum hemorrhage must be excluded? This question is worth 3 marks.
Besides an atonic uterus, the other causes of postpartum hemorrhage that must be excluded include: number 1, retained products of conception; number 2, tears in the vagina or cervical area; number 3, thrombophilias.
Thank you for that insightful response. Now, lastly, please list any 4 complications of postpartum hemorrhage. This question carries 2 marks.
The complications of postpartum hemorrhage include the following: number 1, severe anemia; number 2, Sheehan syndrome; number 3, shock; number 4, infections, including puerperal sepsis; number 5, cerebral anoxia.
Thank you, Rogers, for your thorough and well-informed answers. Postpartum hemorrhage remains a serious condition that requires immediate attention and management. Understanding the risk factors, preventive measures, and management options is crucial for any healthcare provider. We hope this discussion has been enlightening for all our viewers. Thank you for joining us, and we look forward to seeing you in our next session. Welcome to today's video dialogue, where we will explore an important clinical case regarding antepartum hemorrhage. Our focus will be on the implications of this condition in a pregnant patient with a complex obstetric history. Joining us today is Rogers, a medical student who will help us navigate through this scenario. Let us begin. Today, we have a 38-year-old woman, who is a gravida 6, para 5, currently at 30 weeks of gestation. This patient has experienced intrauterine fetal deaths in her previous pregnancies, attributed to placental abruption occurring between 28 and 32 weeks of gestation. As we delve into this case, I would like to pose several questions for your consideration, Rogers. Firstly, can you define antepartum hemorrhage and explain its significance? This question carries 2 marks.
Antepartum hemorrhage is defined as any bleeding from the genital tract that occurs after 28 weeks of gestation until the delivery of the fetus. This condition is significant as it poses risks to both maternal and fetal health, necessitating careful monitoring and management.
Next, I would like you to discuss the differences in presentation between antepartum hemorrhage secondary to placenta previa and that due to placenta abruption. This question carries 4 marks.
In the case of placenta previa, the bleeding is typically painless and presents with bright red blood. This bleeding often occurs without a clear cause and may recur. Additionally, the blood loss usually correlates with the general condition of the patient, and the uterus remains soft and relaxed. Conversely, in placenta abruption, the presentation is characterized by painful bleeding, which is often dark in color, indicating it is older. This condition is frequently associated with identifiable causes such as trauma or premature rupture of membranes. The patient's general condition and level of anemia may be disproportionate to the visible blood loss, particularly in concealed or mixed types of abruption. Upon examination, the uterus is tense, tender, and rigid.
Now, can you explain what a biophysical profile is and describe its components? This question carries 5 marks.
A biophysical profile is a comprehensive assessment performed via ultrasound, typically lasting about 30 minutes. It evaluates fetal well-being by observing fetal behavior and measuring the volume of amniotic fluid alongside continuous cardiotocography. The components of a biophysical profile include: number 1, non-stress cardiotocography. This measures fetal heart rate in response to fetal movements. Number 2, fetal breathing movements. We observe for at least 1 episode of breathing lasting 30 seconds within the assessment period. Number 3, fetal body movements. At least 3 distinct movements should be recorded within 30 minutes. Number 4, fetal tone. This involves assessing muscle tone through the extension and flexion of limbs or the trunk. Number 5. Amniotic fluid volume. This is measured by ultrasound to ensure adequate fluid levels surrounding the fetus.
Lastly, how can the well-being of the fetus be monitored during labor? This question carries 4 marks.
The well-being of the fetus during labor can be monitored through several methods. Firstly, we monitor fetal heart rate using either intermittent auscultation with a fetal stethoscope or Doppler ultrasonic device, or through continuous electronic monitoring of the fetal heart rate. Additionally, it is crucial to assess the patterns of the fetal heart rate, including baseline heart rate, variability, acceleration, and deceleration. Finally, regular checks of the fetal presentation and position are essential to ensure optimal conditions for delivery.
Thank you, Rogers, for your thorough and insightful responses. Your understanding of these critical aspects of antepartum hemorrhage, biophysical profiles, and fetal monitoring in labor reflects a strong foundation in obstetric care. This concludes our discussion for today. Thank you for joining us. Hello, everyone. Welcome to today's Medical Dialogue Challenge. In this session, we will explore a clinical case involving a young mother experiencing some concerning symptoms following childbirth. Our student, Rogers, will respond to the clinical scenario and questions posed. Let's dive in. Today's case involves a 19-year-old primigravida named Miss M, who delivered her first child 7 days ago by spontaneous vaginal delivery. She has presented to the clinic complaining of abdominal pains, associated with a foul-smelling vaginal discharge and fever for the past 2 days. Rogers, can you define puerperal pyrexia and puerperal sepsis? 2 marks.
Puerperal pyrexia is defined as a rise in temperature reaching 38 degrees Celsius or more, measured orally on 2 separate occasions at least 24 hours apart within the first 10 days following delivery, excluding the first 24 hours. Puerperal sepsis is an infection of the genital tract that occurs as a complication of delivery.
Excellent, Rogers. Now, can you list 6 possible causes of puerperal pyrexia? 6 marks.
Certainly, 6 possible causes of puerperal pyrexia include: number 1, puerperal sepsis; number 2, recrudescence of malaria; number 3, cystitis; number 4, pyelonephritis; number 5, mastitis; number 6, wound infections after cesarean section or episiotomy.
Very well done. Now, please discuss the risk factors for puerperal sepsis. 4 marks.
The risk factors for puerperal sepsis can be divided into antepartum and intrapartum categories. Antepartum risk factors include: number 1, malnutrition and anemia; number 2, immunocompromised status such as in HIV patients; number 3, preterm labor; number 4, prolonged rupture of membranes. Intrapartum risk factors include: number 1, repeated vaginal examination; number 2, dehydration during labor; number 3, traumatic vaginal delivery; number 4, retained placental tissue or membranes.
Excellent summary, Rogers. Now, what are 5 clinical signs you would look for during general and systemic examination? 5 marks.
5 clinical signs to assess during the examination include: number 1, raised pulse rate; number 2, increased temperature; number 3, subinvolution of the uterus; number 4, tenderness of the uterus; number 5, hypogastric tenderness, which may indicate spreading infection to the parametrium.
Well articulated, Rogers. Finally, what investigations would you order for this patient? 3 marks.
The following investigation would be appropriate: number 1, high vaginal and endocervical swab for culture and sensitivity testing to antibiotics; number 2, midstream urine for urinalysis and culture; number 3, blood tests including white cell count and hemoglobin estimation, platelet count, and a thick blood film examined for malaria parasites. Additional tests could include blood culture and pelvic ultrasound to check for retained conception products, or abscesses.
Thank you, Rogers. Your thorough responses demonstrate a solid understanding of the clinical scenario and related medical concepts. This concludes our video dialogue for today. Remember, understanding these conditions is crucial in managing postpartum complications effectively. Thank you for watching, and see you next time. Welcome to today's Doc Scenario Video Challenge. In this episode, we will explore a clinical scenario involving an 18-year-old primigravida at 33 weeks of gestation who presents with a history of provaginal bleeding. This scenario will help us assess the appropriate questions to ask, differential diagnoses, examination findings, and investigations. Let's dive in. Rogers, let's begin. In this case, our patient has experienced provaginal bleeding. What are the key questions you would ask her during the assessment?
Thank you, Doc. The questions I would ask are: number 1, what is the color of the blood? Number 2, are you experiencing any associated pain? Number 3, have you been able to perceive fetal movements? Number 4, is the bleeding recurring? Number 5, how long ago did the bleeding start? Number 6, how much blood have you lost in terms of pads used?
Excellent. Now, considering the presentation of provaginal bleeding at this stage of pregnancy, what are your differential diagnoses?
The differentials to consider include: number 1, placental abruption, which is the premature separation of the placenta from the uterine wall. Number 2, placenta previa, where the placenta lies low in the uterus and covers the cervix. Number 3, vasa previa, where fetal blood vessels are present near or over the cervical opening. Number 4, cervical ectropion, which is the presence of the columnar epithelial cells on the cervix. Number 5, genital tract trauma, which may also cause bleeding.
Very good. When examining this patient, what specific findings would you look for?
During the examination, I would assess for: number 1, abdominal tenderness, which may indicate placenta abruption. Number 2, the tension of the uterus. If it is woody hard, it suggests placenta abruption, or a soft uterus may indicate placenta previa. Number 3, the characteristics of the blood. Dark red blood with clots may suggest placenta abruption, whereas bright red new blood in the posterior fornix may indicate placenta previa. Number 4, fetal heart rate, which may be diminished or absent in cases of placenta abruption.
Great insights, Rogers. Now, what investigations would you consider to help confirm the diagnosis and manage the patient?
I would carry out the following investigations. Number 1, a full blood count to check for anemia and any signs of infection. Number 2, an ultrasound scan, either transabdominal or transvaginal, to assess placenta position and fetal well-being. Number 3, a coagulation profile to evaluate for any bleeding disorders. Number 4, a urinalysis to rule out urinary tract infection or other causes of bleeding.
Thank you for that comprehensive approach, Rogers. Lastly, is there any examination you would avoid in this scenario?
Yes, I would avoid performing a digitovaginal examination. This procedure should not be carried out until placenta previa is ruled out, as it may exacerbate bleeding in cases of placenta previa.
Thank you, Rogers, for your detailed responses. This scenario highlights the importance of careful assessment and management in cases of provaginal bleeding during pregnancy. Remember, thorough history taking, examination, and appropriate investigations are crucial in getting treatment. Thank you for watching, and see you in the next episode. Hello and welcome to today's medical video challenge. I am Dr. Scenario, and today we will explore a clinical case involving postpartum hemorrhage. Our student, Rogers, will respond to several questions based on a real-life scenario. Let's dive in. The scenario is as follows. Mrs. Sachula is a 30-year-old woman, G4P3, who had a vaginal delivery at home. Following the delivery of the placenta, she started bleeding severely and was rushed to the hospital. Upon examination, it was determined that the placenta was complete. Rogers, let's begin with the first question. What are the risk factors for postpartum hemorrhage? This question is worth 1 mark.
The risk factors for postpartum hemorrhage include the history of previous hemorrhage, coagulopathies such as von Willebrand disease, a vaginal birth after cesarean delivery, high parity, polyhydramnios, multiple gestation, delivering a large baby, instrumental delivery, and chorioamnionitis.
Excellent. That covers the risk factors. Now, what should be done immediately after delivery to prevent postpartum hemorrhage? This is also worth 1 mark.
The immediate intervention after delivery to prevent postpartum hemorrhage is active management of the 3rd stage of labor.
Great response. Moving on to our next question, what are the medical management options available for atonic postpartum hemorrhage? This question is worth 2 marks.
The medical management options for atonic postpartum hemorrhage include administering oxytocin, methyleugometrin, and misoprostol.
Well done. Next, aside from an atonic uterus, what other causes of postpartum hemorrhage must be excluded? This question is worth 3 marks.
The other causes of postpartum hemorrhage that must be excluded include retained tissues, trauma, and coagulopathies.
Excellent. Lastly, what are the different surgical measures that can be taken to control postpartum hemorrhage? This question is worth 5 marks.
The surgical measures to control postpartum hemorrhage include number 1, ligation of the uterine arteries, number 2, ligation of the ovarian and uterine anastomosis. Number 3, ligation of the anterior division of the internal iliac artery. Number 4, B-Lynch compression sutures or multiple square sutures. Number 5, angiographic arterioembolization. Number 6, hysterectomy if necessary.
Outstanding responses, Rogers. You have demonstrated a strong understanding of postpartum hemorrhage management. Thank you for joining us in this video challenge. We hope you found this discussion informative. Please like, share, and subscribe for more medical content. Until next time, stay curious and keep learning. Hello and welcome to this medical dialogue challenge. I am Doc Scenario, and today we will explore the procedure known as a medial-lateral episiotomy. This procedure is essential in certain obstetric situations to facilitate delivery while minimizing risks to both mother and child. Joining us today is Rogers, a medical student who will help us delve into the details. Welcome, Rogers.
Thank you, Doc Scenario. I am excited to discuss this important topic.
Today, we are presented with a clinical scenario. A laboring woman is experiencing shoulder dystocia during her delivery. The healthcare team needs to decide whether to perform a medial-lateral episiotomy. This is a critical situation that requires immediate attention. Rogers, can you tell us what this procedure is? The procedure we are discussing is a medial-lateral episiotomy. It involves making a surgical incision in the perineum to enlarge the vaginal opening during childbirth. Excellent. Now, can you list any 2 indications for performing a medial-lateral episiotomy?
Certainly, 2 indications for this procedure include shoulder dystocia and the inability to insert instruments required for assisted vaginal delivery. Other indications may include breech delivery or when labor is progressing too quickly.
Very good. What are the steps involved in performing this procedure?
The steps to perform a medial-lateral episiotomy are as follows. Number 1, obtain informed consent from the mother. Number 2, administer local anesthesia to the area to ensure comfort. Number 3, position the mother in the lithotomy position for optimal access. Number 4, clean the area with an antiseptic solution to reduce infection risk. Number 5, place a finger or 2 between the fetal presenting part and the perineal skin to guide the incision. Number 6, with sterile episiotomy scissors, make a cut through the perineum at the desired site. Number 7, after delivering both the baby and placenta, suture the perineum back together using catgut sutures.
Thank you for the detailed explanation. At what point during labor is the ideal time to perform this procedure?
The ideal time to perform a medial-lateral episiotomy is when the fetus crown.
Great. Now, what complications may arise from this procedure?
Two potential complications of a mediolateral episiotomy are postpartum hemorrhage and fecal incontinence. Other complications may include wound infection and an increased chance of perineal tears in future vaginal deliveries.
Thank you, Rogers. Can you also elaborate on the types of episiotomies that exist?
There are two main types of episiotomy, the midline episiotomy and the mediolateral episiotomy.
Excellent. Now, let's discuss the advantages and disadvantages of the mediolateral episiotomy. Can you share some insights?
Certainly, Dr. Scenario. The advantages of a mediolateral episiotomy include minimizing the risk of anal sphincter injury and facilitating the management of a prolonged second stage of labor, which can ultimately lead to a faster delivery. On the other hand, the disadvantages include increased pain and discomfort for the mother, a longer healing time, and a higher risk of long-term dyspareunia.
Thank you, Rogers, for your thorough and insightful responses. This discussion on mediolateral episiotomy highlights its importance and the considerations involved in obstetric care. We hope this dialogue has been informative for our viewers. Thank you for joining us today, and we look forward to seeing you in our next medical challenge. Hello, everyone. Welcome back to our Doc Scenario Challenge series, where we put our medical knowledge to the test. Today, I'll be joined by Rogers, a dedicated medical student, as we work through a case related to amenorrhea and ovulation. Rogers, are you ready?
Yes, Doc Scenario, I'm ready to dive in.
Great. Let's get started. Imagine a patient presenting with complaints of absent menstrual periods. Let's walk through the concept of amenorrhea and related questions. My first question, can you define primary and secondary amenorrhea?
Certainly, Doc Scenario. Primary amenorrhea is defined as the absence of menstrual periods by the age of 16 in the presence of secondary sexual characteristics, or by the age of 14 if there are no secondary sexual characteristics. Secondary amenorrhea, on the other hand, refers to the absence of menstrual period for at least 6 months in someone who previously had regular menstrual cycles.
Good, Rogers. Now, let's move on to the next question. Can you tell me some common causes of primary amenorrhea?
Of course, common causes of primary amenorrhea include anorexia nervosa, excessive physical or psychological stress, Coleman syndrome, hyperprolactinemia, hyperthyroidism and hypothyroidism, Cushing syndrome, androgen secreting tumors, congenital adrenal hyperplasia, Turner syndrome, anatomical abnormalities such as an imperforate hymen, transverse vaginal septum, and Morellian agenesis.
Excellent, Rogers. You've covered a comprehensive range of causes there. Now, let's take a step back and discuss the physiology. Briefly explain how menstruation occurs.
Certainly, the menstrual cycle involves a complex interplay of hormones and physiological changes in the female reproductive system. In the menstrual phase, which typically lasts 3 to 5 days, menstruation begins if the egg from the previous cycle remains unfertilized. At this point, estrogen and progesterone hormone levels drop, causing the thickened endometrial lining, which would have supported a pregnancy to shed. This results in menstrual bleeding as the endometrial lining exits through the vagina, accompanied by a mix of blood, mucus, and tissue from the uterus. Common symptoms during this phase may include cramps, tender breasts, bloating, mood swings, irritability, headaches, fatigue, and low back pain.
Very well explained, Rogers. Now, one final question for you. Name 2 drugs commonly used to induce ovulation, and explain their mechanisms of action.
The 2 drugs commonly used to induce ovulation are clomiphene citrate and letrozole. Clomiphene citrate is a selective estrogen receptor modulator. It works by competitively inhibiting estrogen's binding to its receptors at the hypothalamus and pituitary gland. This inhibition induces the release of gonadotropins from the pituitary gland, which in turn stimulates ovulation. The drug is typically started on days 3, 4, or 5 of the menstrual cycle, and the ovulation generally occurs 5 to 12 days after the last pill is taken. Letrozole, initially developed as a treatment for breast cancer, also promotes ovulation. It does so by inhibiting estrogen production, which indirectly stimulates the release of follicle-stimulating hormone and luteinizing hormone from the pituitary gland.
Fantastic work, Rogers. You have provided detailed, accurate responses across all the questions. Thank you for participating in this doc scenario challenge. To our viewers, I hope this session has been informative and reinforces your understanding of amenorrhea and ovulation. Until next time, keep studying and keep challenging yourselves. Welcome to today's doc scenario challenge video. In this session, we will cover a case on infertility, a common yet complex area in reproductive medicine. Our student, Rogers, will be walking through this case with me, answering a set of questions based on the key concepts and clinical approach to infertility management. Rogers, are you ready to begin?
Yes, I am, Doc Scenario. Let's proceed.
Alright, Rogers, let's discuss infertility, defined as the inability of a couple to conceive after 1 year of regular unprotected intercourse. For today's case, imagine that you are approached by a couple experiencing difficulty conceiving, and they want to understand their situation better. I will ask you a series of questions to cover different aspects of this topic. Let's start with definitions. Rogers, could you define primary and secondary infertility for me?
Certainly, Doc Scenario. Primary infertility refers to cases in which the female partner has never conceived before. In other words, the couple has never achieved a pregnancy. On the other hand, secondary infertility denotes a situation where there has been a previous pregnancy, but the couple is now unable to conceive again. This means that the female partner has previously conceived even if the pregnancy ended in miscarriage or termination.
Excellent, Rogers. Now, let's discuss the main causes of infertility. Can you list the primary causes?
Yes, the main causes of infertility can be categorized as follows. Number 1, ovulatory disorders. These involve irregular or absent ovulation. Number 2, tubal factors. This includes blockage or damage to the fallopian tubes. Number 3, uterine abnormalities. These are structural issues within the uterus itself. Number 4, endometriosis. This involves the abnormal growth of uterine tissue outside the uterus. Number 5, male factors. These refer to problems with sperm production or function. Number 6, unexplained infertility, when no specific cause can be identified. Additionally, there are several general factors that may contribute to infertility, including advanced maternal age, particularly in females over 35 years, where the quality and quantity of oocytes decline significantly. Other contributing factors include smoking, which can reduce fertility in females and negatively affect semen quality in males, and excessive alcohol consumption, which can harm sperm quality and developing fetus. Factors related to coital frequency also play a role. For instance, stress and anxiety can affect libido, thus impacting frequency, with a recommended coital frequency of 2 or 3 times per week. Body weight is also critical, as being either overweight or underweight can impact ovulation. Women with a body mass index of over 29 or under 19 may find it difficult to conceive.
Well explained, Rogers. Now, let's move on to tubal factors. What are some common methods to investigate tubal factors in infertility?
2 key methods are used to investigate tubal factors. The first is hysterosalpingography. In this procedure, a contrast dye is injected into the uterus and X-rays are taken to visualize the fallopian tubes and check for any blockages. The second method is laparoscopy, which is a minimally invasive surgical procedure that allows direct examination of the pelvic organs, including the fallopian tubes. This enables the physician to identify any blockages or abnormalities in the tubes.
Good, Rogers. Now, imagine this couple is looking for guidance on basic steps they could take to address their infertility. What general management steps would you recommend?
In managing infertility, it is essential to approach the couple holistically. Here are some key steps. Number 1, consultation together. It is important to see both partners together to understand their shared concerns and to address any individual issues. Number 2, privacy and time. Ensuring sufficient privacy and clinical time can help make the couple comfortable and provide a thorough consultation. Number 3, detailed history taking. Taking a detailed history with a focus on their anxieties and concerns is essential. Number 4, counseling and instructions. Counseling plays a crucial role in addressing any anxieties, and specific instructions are provided to the couple. Number 5, routine examination. Routine physical examination is generally not necessary unless indicated by the history. Number 6, lifestyle modifications. Encouraging an optimum body mass index between 20 and 24, reducing or avoiding alcohol and smoking, and addressing coital timing can be very helpful. The couple should be advised to engage in intercourse every 2 to 3 days, particularly during the mid-cycle phase to optimize conception chances. If there are ovulatory concerns, they may consider using a luteinizing hormone test kit to detect the LH surge in urine, which shows a deep blue color change on the dipstick between days 12 and 16 of a regular cycle. Timed intercourse over the 24 to 36 hours following this color change could improve conception chances. Lastly, minor psychosexual issues should be addressed appropriately and reassurance is provided throughout, as infertile couples are often psychologically disturbed.
That was a comprehensive answer, Rogers. This concludes our session on infertility. Thank you for your thorough responses, and I hope this discussion provides valuable insight for everyone watching.
Thank you, Doc Scenario. It was a great learning experience.